Today's program is being made possible as part of a collaboration between the University of Illinois Extension and Southern Illinois University School of Medicine, the Office of Population Science and Policy. Dr. Vora is a research and policy expert and a practicing pediatrician and professor of pediatrics at the Southern Illinois School of Medicine. Dr. Vora has received several honors, including a United States Fulbright Scholarship in 2009 and a 2014 American Association Foundation's Excellence in Medicine Leadership Award. He recently was named an Edgar Fellow in 2016, one of 40 emerging political and policy leaders in Illinois. And he was most recently named to Springfield's Business Journal's 40 Under 40 for his exceptional leadership in the community. So it's with great pleasure that we introduce our programming partner today, Dr. Samir Vora.
Well, thank you so much for the introduction, Kathy, and a pleasure to be part of the University of Illinois Extension webinar series. And thanks to all those who are sacrificing their noon hour to come have a conversation about social determinants of health and how the healthcare setting and the healthcare enterprise are tackling issues that we always knew about, but now are starting to really understand and determine when achieving the most important thing that we value, the health and the health outcomes of the residents across our state and across SIU's large service region in central and southern Illinois. So the title of this talk is Healthcare's New Frontier, Addressing the Social Determinants of Health. But before we begin, I wanted to sort of celebrate today being National Rural Health Day. And for many of those on the call and working across our rural spaces across of Illinois, wanted to wish everybody a National Rural Health Day, and that hashtag, the power of rural, is something that we have seen in our office and all of the wonderful and exciting things happening across rural Illinois in ways to improve people's health and all the innovation that is there. And so wanted to wish everybody a National Rural Health Day. So as a physician and as somebody speaking to you from a medical school, physicians discuss and think about the Hippocratic Oath, and it's a thing that we value so much in the way that we go about our practice as physicians. And in that Hippocratic Oath, there is a very important passage that often isn't able to be fulfilled in the way that we try and want to do in our clinical settings, in our clinics and our hospitals. And that phrase is, I will remember that I do not treat a fever chart, a cancerous growth, but a sick human being, whose illness may affect the person's family and economic stability. My responsibility includes these related problems if I'm to care adequately for the sick. But many of you who have gone to the clinics and hospitals know that much of what we do in a clinical space is about the diagnosis and treatment of disease. But what affects that diagnosis and treatment of disease is so much beyond that individual disease, but the way that people can get to healthcare, the transportation needs, how people's socioeconomic or healthy behavior end up determining how they can be healthy and how they can adequately care for themselves and their families when they're sick. And that is a challenge for the healthcare community. But it didn't used to be in the same way. And often when we think about the traditional community doctor, and this picture sort of purposely in black and white, because in so many ways the doctor used to be a community doctor who understood the community's needs, understood individuals, not just from their disease, but understood their families. They often had their children go to the same schools as individuals in their community. And this was the epitome of what that traditional community doctor was, made home visits, understood the challenges that people faced in their homes and outside their homes, and how those determined somebody's health. But today, the doctor is someone that you often see in a very specific place. in a hospital, in a clinical setting, often in ways that are separated from the patient. We know that we are doing this for the right reasons to make sure that we're not passing along diseases. But often you see a doctor in a yellow gown and a mask, a doctor sort of removed with a lot of technological gadgets that separate what is happening between that personal relationship between the doctor and the patient. And although we've made vast improvements in the way that we think about disease and how we can sort of treat that disease, we've created sort of that separation between knowing what a person is and how that person lives within their family and their community and how that affects health. And this is during a time where the amount and ability of scientific aspects of medicine are just incredible. And we have recently sort of found and discovered nanobots that can go into cancer cells and destroy them within. It's like we're watching Ant-Man or some superhero kind of do incredible things. We have the ability to print organs so that ears, kidneys, etc., we no longer have to think about transplants, and that science continuing to emerge. And almost in every operating room, hospital across the country, there's this emergence of robotic surgeries. So you don't even see surgeons near the patient's bedside. Instead, they're working on ways to do it in minimally invasive ways. But despite this state of medical technology, we as the United States struggle in terms of health outcomes compared to our neighboring developed countries. That in this sort of chart of 11 countries that we would sort of call our economic peers, despite spending almost $3,000 more per person on healthcare than even our number 2 individual country, we have the worst health outcomes of those 11 nations. Worst in sort of healthy lives, worst in health equity. And so what is it in our system where we are spending so much money per person on healthcare, but not having the same healthcare results as some of our comparable first world countries? And the answer to that is complicated, and it's complicated for a variety of reasons. And I'm going to do this a little bit of injustice, but kind of try to summarize some of the main reasons for that vast difference. And it's because there are certain individuals in the United States that do have the best health outcomes in the world. But compared to other countries, we have vast disparity in those individuals that have the greatest health care and those that have the poorest health care. And so what does a disparity mean? And a disparity is defined in relation to a socioeconomic position and ethnicity, race, geography, gender, and age, and in the context or combination of these and other factors. And disparities should be defined not simply as a difference, but as an inequitable difference that is potentially systematic and avoidable. So that's an important difference. So it's an inequitable difference that is both potentially systematic and avoidable. And when we think about health disparities, there are different levels of health disparity. And the foundation of this pyramid is about what your exposures and opportunities are as an individual. So if you happen to live in a situation where you have resources, economic resources, educational resources, a community that allows for things and for opportunities for children to succeed and thrive, your level of health disparity allows you to achieve, allows you as a child to dream and be able to achieve more things. The difference between sort of where we start and the exposures and opportunities that we have. And those exposures and opportunities allow and differentiate how healthy we can be. And that foundation leads us to access to care. And access is not just the idea of having insurance, but how close you are to a healthcare facility. Does your insurance, is it good enough to allow you to get the type of health care that you need? And in the end, what is the quality of that health care? And we know that quality differs based on our access, but also in certain situations, what is available to various patients. And many of you come from rural Illinois. And we know that in rural areas, there are challenges. There are challenges to access in terms of providers. And there are different sort of behaviors and cultures compared to urban America. And what has been a great privilege of traveling across rural Illinois is that there's incredible things happening. But the statistics, unfortunately, show that individuals in rural areas do happen to have worse health outcomes than their urban counterparts. And so, on average, it's about 15 to 20% of all Americans live in rural areas. Only 1 in 4 rural adults practice at least 4 or 5 of what we would consider positive health-related behaviors. Not smoking, maintaining normal body weight, being active, non-drinking or moderate drinking, or sufficient sleep. And so those health behaviors ultimately determine how healthy someone is. Also, Americans living in rural areas are more likely to die from the 5 leading causes of death than their urban counterparts: heart disease, cancer, unintentional injuries, chronic lower respiratory disease, and stroke. And so those 5 leading causes of death worse in rural areas across America than urban areas. And there are vast differences in the workforce, especially around physicians, in rural areas versus urban areas. So if we take America, in rural areas, for every 100,000 people, 55.1 primary care physicians per 100,000 residents. And in urban areas, we found that there are 79.3 primary care physicians per 100,000 areas. But that difference with specialists is incredibly vast. So in rural areas, there are about 30 specialists per 100,000 residents. And in urban areas, there are 263 specialists per 100,000 residents. And we see that there are increasing rural hospital closures across the country. 80 rural hospitals in 26 states have closed in the last almost 8 years, since January 2010. And as a pediatrician, rural America's children are incredibly important to me. And a higher percentage of children in rural areas compared with urban areas had parents who experienced financial difficulties meeting basic needs such as food and housing. Children in rural areas more often lacked amenities and lived in a neighborhood in poor condition. And 1 in 6 rural children had a mental, behavioral, or developmental disorder. And we know in this work that there is a much greater number probably that just haven't been diagnosed. And children with mental, behavioral, or developmental disorders more often lacked a medical home, had a parent in poor mental health, or lived in families with financial difficulties than children without mental, behavioral, or developmental disorders. And after adjusting for poverty and race and ethnicity among children with mental, behavioral, developmental disorders, those in rural areas more often had a parent with poor mental health and lived in resource-low neighborhoods than those in urban areas. And that sort of leads to what has been this great challenge around children who have faced adverse childhood experiences. And adverse childhood experiences are those experiences in childhood from trauma, neglect, from a parent who uses substances, from a parent who is incarcerated, divorce, transient sort of nature of where you're able to live and sleep. And those kids suffer from social, emotional, cognitive impairment. They're often developmentally behind their peers, and those things stand with poor developmental outcomes and even academic achievement. Children as early as 18 months, when in the lowest quintile of income, they tend to fall back behind up to 6 months from average for those in the top quintile of income and education. And even by the time that we are at 5th grade, kids in the lowest quintile of income and education are 2 to 3 grade levels behind average. And we all hope that our children are higher than average in terms of academic achievement, so we show that range grows as children age. Those kids also tend to adopt those higher health riskier behaviors that we saw in an earlier slide. And they tend to have cardiovascular disease, diabetes, and social problems at an earlier age, and ultimately lead to earlier death. And 2.5 million people are suffering from opioid addiction across the country. And opioid overdose deaths are 45% higher in rural areas compared to urban areas. And we saw an increase in 2008 to 2014 of rural communities saw a great increase in neonatal abstinence syndrome, 2.5 times higher in rural areas compared to urban areas. And this is a map of Illinois' health outcomes. And as we see, this is from the Robert Wood Johnson Foundation and the University of Wisconsin, that those in darker green are the areas in Illinois with worse health outcomes. And we see the best health outcomes sort of are around the collar counties in Illinois, but the worst health outcomes really are in southern Illinois, the darkest of the darkest green. And our rural areas, compared to especially those collar counties around Chicago, have the worst health outcomes in the state. And 21 of 25 SIU as a service region in southern Illinois of 66 counties, those areas, 21 of the 25 worst health outcomes happen to be in those areas. And this is a map of pediatricians in our service region, and pediatricians sort of across the state. And as we see from this map, of the 102 counties in Illinois, 46 of them don't even have one pediatrician in the whole county. And of the SIU 66 county region, 36 out of 66 don't have one pediatrician. So let's kind of talk a little bit more about these sort of social determinants of health. And what is social determinants of health, and how do we define it? And social determinants of health are the structural determinants and conditions in which people are born, live, work, and age. They include factors like socioeconomic status, education, the physical environment, employment, and social support networks, as well as healthcare. We see with that kind of designation that those social determinants are what ultimately determine somebody's health outcomes. And we find that 80% of somebody's health is defined by things outside of the healthcare system. 40% of those happen to be socioeconomic factors, education, employment, income, family social support, community safety. 30% of them happen to be healthy behaviors, tobacco use, diet and exercise, alcohol use, and 10% happens to be in their physical built-in environment. And so of the 100% of somebody's health outcomes, most of what is really determining how healthy they are happens to be outside the healthcare system. And so when we're thinking about somebody's health, we got to think about their economic stability. We have to think about their neighborhood and physical environment. We have to think about their education, their access to food, their community and social context. And for the most part, the medical community has not engaged in those areas. First and foremost, because we are far from the experts at all in those areas. But we do play a role as many of the patients as we determine their health. How do we work better systems and with our partners who are experts in those areas to really determine how to truly understand all the factors that determine somebody's health and then subsequently do something about that? And so we see social determinants of health are different things all across various aspects. And it's really about health in all factors of society and health in all policies. And in truly understanding how to make our society, our communities, and our countries better, we have to start looking at health from this prism beyond disease and that treatment of the disease, but all the factors that work on making somebody as healthy and happy as possible. So what is medicine's role? And we just sort of talked about how medicine hasn't really understood or really acted on determining the health of and the social determinants of health and really tackling that 80% outside of the confines of the healthcare system. And so this started to change about 10 to 12 years ago. And what happened was there's sort of a new understanding of what the Institute of Healthcare Improvement defined as the triple aim. This idea that in order to really treat people well, we had to do things around the best experience of care. We had to treat people in most efficient ways, and we had to sort of also treat the health of populations. And treating the health of populations is unique for physicians. As I go into my clinical practice, I see a family, but I see one patient at a time. So how could we better understand things from a population perspective if we really wanted to help and determine and improve health? But how do we define the health of populations? And it's a complicated definition because people don't know truly how to appropriately define it. One definition shows the health outcomes of a group of individuals, including the distribution of such outcomes within a group. We are the health of a population as measured by health status indicators and is influenced by social, economic, and physical environments, personal health practices, individual capacity and coping skills, human biology, early childhood development, and health services. And so the first definition, incredibly vague and sort of mirrors almost anything that you could throw in. And the second definition decided to actually throw in almost every indicator of society. And so the way that we like to think about health and population health is sort of as a conceptual framework of thinking about why certain populations are healthier than others. And medicine has slowly tried to move to be better in terms of health equity, in determining this concept that everyone should have a fair opportunity to live a long and healthy life. And in doing that, we have to understand those foundations around health and truly understand that things beyond disease and that those socioeconomic environments, those healthy behaviors, play a great role in understanding and giving everybody that fair opportunity to live a long and healthy life. But the reality is that we don't live in a society where health equity is easy. Because if we try to mirror equality, we know that people start from different foundations, and people aren't going to achieve the same health if we give everybody equal health. And we know that if we try to do health equity, that certain people are going to need a little bit of a boost to get to that spot where they have that fair opportunity. But the reality is that when people start in certain places, their ability to be healthy, they have that great foundational support. And people who struggle often aren't able to dig out of those struggles to really achieve the kinds of success that they need and the kinds of opportunities that they need to lead those healthy and active. And so we're back here. We're back to the social determinants of health. And we're back to trying to think about ways that we can make a difference in improving health outcomes. So now I'm going to talk to you about what we're doing at SIU School of Medicine to better understand this role in our social determinants of health and better work to improve the health outcomes of our service region. And so the school was founded in 1970 to fulfill a mission for the 66 counties in central and southern Illinois to assist the people of central and southern Illinois in meeting their healthcare needs through 4 pillars. Education, so we teach and provide the next generation of physicians and other mid-level providers, that we do our best in clinical care around the care of patients. We research as a university to think about innovations. And the last pillar, which was added 10 years ago, was service to the community, that we would do things at Southern Illinois University School of Medicine to achieve the mission of the medical school and to achieve the mission of the region by serving their needs. And this is our region. It's the region in color. And it's a lot of geography, 66 counties, 32,000 square miles, 2.2 million people. And we're headquartered here in Springfield, Illinois, but we have satellite clinics and offices in Quincy, Decatur, and Carbondale. And we, through our Office of Regional Programs, have satellite offices in Canton, at Graham Hospital, and in Mattoon at Sarah Bush Lincoln, and in Carbondale with their Center for Rural Health and Social Service Development, working on relationships, partnerships, and really understanding the region. And so we asked ourselves about 13 months ago 2 big questions. One, could members of SIU Medicine's faculty and staff work to not only improve the health of individual patients, but also improve the health of populations? And could we as a medical school and a healthcare enterprise understand why certain populations are healthier than others? And then try and figure out the appropriate mechanisms to make a difference to improve those individuals' health. And so in doing so, we launched the Office of Population Science and Policy to improve the health of residents in Central and Southern Illinois through research, policy, and education. And the Office of Population Science and Policy serves to both meet those missions of research and service to the community to better understand the needs of our service region, mostly rural, and to also figure out the right kinds of innovative practices that can improve those individuals' health, and do so by sustaining that change through policy change. And so, again, what is population science? And the way that we define it is understanding why certain populations are healthier than others, and using that knowledge to design programs and interventions to make populations healthier. But our name is long. It is the Office of Population Science and Policy. And so why policy? And we're doing policy to create the systemic change necessary to provide sustainable solutions for the residents of Central and Southern Illinois. And this is our mission. It's understanding and advancing the health, development, and wellness of residents in Central and Southern Illinois. And we're doing it through 3 kind of distinct divisions. The first division is our science division. And in the science division, knowing that the health problems across Illinois are vast, that in the first years of our formation as the Office of Population Science and Policy, we had to concentrate on a few specific issues and a few specific items that we felt that were in the best and most urgent need in our communities, but also that we had the best expertise to actually achieve. And so we divided this into 3 tiers. The first tier was around the disparities of cancer in our service region, cancer being one of those things in our 66 counties that rose to the top of individuals' community health needs assessment and individual public health eye plans, and also the disparities around the health of children. We also, our tier 2 was sexually transmitted infections and respiratory health. And increasingly across our service region and rural counties across the state and country, we found that in our early 15 months of existence, that the opioid challenges were something that our region needed to better tackle and understand, and we made that a priority in our office. The second division is what we call social innovation. And this idea that communities had a lot of incredible things going on, but they needed to better sometimes understand how to use the data that they were collecting, how to create a project that you were doing a targeted, measurable goal, and showing that the resources that were put into that goal were actually being achieved. And so we, through not only public health professionals, but anthropologists and sociologists, have worked on a process of developing and deploying effective solutions to challenging and often systematic social and environmental issues in support of social progress. And I can't think of an issue that is more important in terms of social progress than thinking about the health of our communities. And so we've been designing our work around helping our communities become healthier. And often there's little help that they need, right? We just are kind of coming alongside them to work with issues that they say are important, but finding the right ways to appropriately situate them in a way that they can be most successful. And so that is the work that we're doing around our social innovation division. I think when we talk about this idea of policy, of how we can try to allocate resources so that they are sustainable. And much of what we find is that policy, when we think about policy in terms of state and federal legislation. But really impacting policy goes down to the school district policy or our healthcare policy or the policy of the companies that we work in. Because we know that when a handbook, when the policy changes, resources change too. And so all of our science and social innovation projects and programs have a goal around policy. And we're working on things to sort of gather what the innovative policy programs and projects that are happening across Illinois. We're slowly starting to have increasing rural health convenings of individuals from all sectors of society, because we're talking about all the different items that affect health, these social determinants. We're analyzing state and federal law to see what policies are truly make a difference, and we're trying to create and have the solution generators for us as an office to be both a do tank and a think tank. So our goals in SIU's Office of Population Science and Policy is this idea of we want to build healthy Illinois futures. And we want to do it around innovation. We want to do it around policy. We want to do it around education. But that what we know is that we in the medical community are not going to be the experts. The experts are the individuals in these communities that are working every single day to make their communities better. And we to be the support pieces to help address those social determinants of health and make those communities as healthy as they can be and achieve health equity. So I'm going to talk about 3 of our projects and then kind of leave some time for questions. One happened to be in Hillsborough, Illinois. And for those that have visited Hillsborough Hospital, it's a truly special place because Hillsborough Hospital has turned into a community center. At Hillsborough Hospital, there's a daycare in the hospital. There's a gym in the hospital. And the hospital serves as a place for community events, for auctions. And unlike things in many hospitals sort of across the state. And we had this idea of how we wanted to help close that developmental achievement gap that we talked about earlier. And when we went there and talked about first thing first for me as a physician is to think that there was a clinical solution to this. And what the hospital CEO told me is that, well, we don't employ any of our doctors. They come from bigger systems. They just have privileges in our hospital. But we do have a daycare, and in that daycare there are kids from 0 to 5. Could we make a difference in their foundation to help build a healthy, active brain so they could develop and mature? And so in combination with the community, we started a program called Little Leaps. And in Little Leaps, it was working with their daycare and working with the hospital itself to change parent engagement to help improve the developmental outcomes of children in Hillsborough. And we did it based on how we think about development in a pediatric clinic. That we were going to work on ways in well child visits. And often, as many of you know, when for your kids and grandkids, is that you go to the doctor's office a lot when they're young. And doing so are many ways that brain forms so rapidly that when they're first born, peeing, pooing, crying, sleeping, and that's about it. And then by 4 and 5, they're asking the most amazing questions and the attitude that comes from them. And as a father of a 4-year-old girl and an 8-month-old girl, we've seen sort of that great developing brain. And so what we're doing is we're thinking about ways, and we've created these developmental bags, all under $7, that we can sort of meet and increase parent engagement to improve developmental outcomes. And also, we've worked on a system in Little Leaps to help try and change and affect certifications and regulations around daycares, so that daycares doing these kinds of programs will have the opportunities to have appropriate certification and be seen as valued daycare centers. The second project is working within the schools, and it's a project that we've been partnered with the Illinois Education Association, and specifically in Macon and Piatt County around school health and school achievement. And what we've been doing in Decatur is thinking about trauma-informed schools. And Senate Bill 100 passed a few years ago in Illinois that said that teachers couldn't, and principals, administrators, couldn't expel children, and they couldn't have a zero tolerance policy. They had to create mechanisms in place to allow those children to figure out different ways to make an issue and an impact. But teachers didn't know, and school administrators didn't know how to appropriately design the spaces for that innovation to happen, and there wasn't funding to allow that to happen either. And so we came alongside the Regional Office of Education, the Illinois Education Association in Decatur and Macon and Piatt County, and the Educational Coalition of Macon County to create and measure the spaces for teachers to be innovative, to change curriculum, to better allow children an opportunity to grow and to take on different roles so that they could understand how the brain develops, how those kids who faced excessive stress, they need to be and react in different ways in different situations, so we can lead and be in a position where those children could grow and learn. And this project has sort of taken off over the last 6 months, and the amount of space and the innovation that's already happening in Macon and Piatt County is truly remarkable. And we've been partnering with the Illinois Education Association to expand this work across central and southern Illinois. And then finally, our work in the lower 16 counties in the Illinois Delta region around the opioid epidemic. And we're partnering with the University of Chicago and the Illinois Department of Public Health to investigate and understand how factors such as places of residence and local culture impact infectious disease spread and treatment among people who inject drugs. Because we found that the rates of hepatitis C, HIV, etc. have increased in vast rates for people who inject drugs. And because of the opioid challenges, so many people who started on prescription drugs now have moved to heroin because it's cheaper, and they've sort of faced addiction. So we're developing interventions to expand services designed to reduce disease transmission, identify and treat those infected, and increase linkage to additional treatment and medical care. And so we're back a little bit where we started. That in order to truly understand and improve somebody's health, we have to go back to the pillars of what it means to be a doctor. And in our office, we're sort of adapting that Hippocratic oath to meet the mission of our region and meet the mission of our individual office. And so we are saying we will remember that we care for human beings whose health may be affected by the person's family and economic stability. Our responsibility includes these related problems if we are to care adequately for the sick. And the SIU School of Medicine, with its leadership, has said that it is our social mission, and we are socially accountable to the health outcomes of our region. And in order to improve those, we have to understand and tackle the social determinants of health. And so our request to you and the partners in this call across the state is that this is hard work. And we don't pretend to be the experts, and we know that the partnerships need to form in a myriad of ways to make the type of impact and difference to start helping and improving these social determinants of health. And we request that for you, because for all of us, the goal is a healthy Illinois. A healthy Illinois so a pregnant mom can sort of think and achieve whatever she wants with children from across the state. To make sure that an elderly couple has the same quality of life in their years to be able to do and achieve the things that they want. For a growing family to know that there's opportunities for healthy behaviors and healthy support structures to allow them to grow. And a child to be able to dream that they can be anything and anyone in this great country. And so that's the goal of our office. We want to improve the health of residents in Central and Southern Illinois through research, policy, and education. And we're beginning to do that at the SIU School of Medicine through our Office of Population Science and Policy. So I want to thank you to everybody for their patience through this talk and the technical difficulties that happened, and happy to spend these last 10 minutes answering questions. And I saw a few of them come through through the chat mechanism, and I can begin answering those as well.
Thank you very much, Dr. Bora. So if you're looking at the chat space, I think we could start maybe in unpacking a little bit around what's happening in Hillsborough. How was that funded, and have you begun to look at all yet regarding the economic impact of those practice changes in the community? So
the Hillsborough Daycare Center is sort of a unique partnership that's funded by the school district and the hospital. And so that's how the daycare in and itself was funded. And so our Little Leaps program came with this idea that in order to fund both the bags and the evaluation, that we needed some support. And so our office, with some Hillsborough community members, went out and sort of raised money from Hillsborough itself. And so the hospital CEO was this great leader and innovator, and we did sort of various different mechanisms from the hospital community benefit dollars, but also from resources from the community themselves to raise that money for the bags, for the research evaluation. And what we found is that there was so much interest in Hillsborough. The first meeting was me just with the hospital board, and members of the community were invited, and 60 individuals showed up. And when we did the launch with the parents of the community, over 100 showed up, 40% of that being dads. And I think part of what we've been discussing with our communities is that we do need a catalyst of funds to allow these programs to grow and launch. And some of that has been this investment in the communities to provide that through hospital community benefit dollars, through the communities themselves saying that this is important and they want to make a difference. And we felt so inspired by that within those communities.
That's terrific. And you talked about in those comments, Dr. Bora, a little bit about the community engagement piece, but are there other things that you want to add about strategies for making this really truly a community-based effort?
Yeah, and I think that is, when we go in each and every community, it's partly based on a foundation of what they've identified as their most glaring health problems. And as we talked about a little bit, we're just not ready to tackle each and every one just based on kind of our expertise and sort of the growing nature of the office. But, when we talk about obesity being a problem, or children's mental health, or access to services, those are very large terms. And what we often do is say that, okay, we have to know who the stakeholders are in that community, who can make the difference, but how do we first define the problem in a very targeted way? And then our big goals, especially around our social innovation work, is that we don't come to anybody with this sort of plug and play model. And a lot of evidence-based research comes and says that this is the gold standard program to improve a child's health. But that gold standard program often worked in communities that are very different than the community that we enter. And we know that even in the 66 counties that SIU serves, each and every community is different. And so we might have the same problems, but the solutions are going to be geared on what that community says, the resources that they have, and what they can achieve. And we found that in Hillsborough, we found that in Macon and Piatt County. And it's our job to kind of modify that. And much of that is, how are you going to collect data? How are you going to show that it's effective? But so much of these arenas, whether it's the schools or the public health departments, they already collect so much data. And our job has been taking that data, analyzing it sort of as a pre-intervention, and then ultimately seeing what happens when we make a difference. But we know that progress is going to be slow, and we know it's going to take time, and so that's why we're measuring both with, with tools and surveys and even different sort of health outcome measurements, but also sociologically, that are we making an impact around, the anthropologic, the cultural aspect of the community, but also the sociologic, and those are things that we've taken on as experts in our office, public health, sociology, anthropology, business, etc., to see, are we making a difference and are we moving things forward. And so we often say that we work with the community, but the community, what they view as important, it has to start there, because that's the only way that we can think about the project, we can work in sustainability goals around policy, and ultimately that will last well beyond SIU Medicine's involvement in that community.
Terrific. I think there may be one more opportunity to think about the economic analysis piece. Dr. Boer, have you talked about that? And while I think I've got two more questions on the board. I'm going to put up a poll just to ask participants to give us a little bit of feedback on the content of today's webinar. So, but go ahead with your question. Can you share a little bit about what you're thinking in terms of economic analysis, when that might occur, or if you're planning for that?
Yeah, no, I see that the esteemed Norm Walser asked that question, and I think that we haven't gotten to that point, but it's something that we feel is instrumental in this work moving forward. And Norm's been sort of a great person to discuss these issues with, because ultimately we feel that if we're talking about the socioeconomic status, which is a central part of those social determinants of health, those economic impacts are going to drive the ability to change and improve health outcomes. And so I think that that's the road we're on. We're quite not there yet, but we've been working with the hospital systems to better see how, when we address social determinants, we see the economic improvement in the hospitals. Now we got to broaden that out to see how we see the economic impact in the communities themselves. And we love the guidance and partnership from leaders across the state who are thinking about those issues. We've had some conversations with the Federal Reserve Bank in Chicago, et cetera, to thinking about those kinds of things. But how do we relate that into action is something that is a future goal of the office, and seeking partners to help us achieve that.
Fantastic. That's terrific. Really great examples. And I think going forward, our quest is really to elevate this conversation all across the state, and really to create even more conversations around what can we do as a community to deal with these health disparities. Our next presentation for the local government webinar series will be on December the 7th, and we're going to have the pleasure of another SIU School of Medicine representative sharing with us information regarding work that Dr. Samir Vora has started today, that notion of health in all policies. And Laura Kessel with the SIU School of Medicine, the Office of Regional Programs, will be presenting on the 7th. So please join us again in a couple of weeks to learn more about ways that we can engage community in this kind of problem solving around health issues. So thank you very much, Dr. Vora. We've very much enjoyed your presentation. Thank you for joining us.
Thank you so much for the invitation.